Recording in progress.
Hi. So good afternoon. I'm Dr. Vatsala from the Department of Peadiatrics. So today our CLD is on common respiratory and CVS conditions in childhood. So what we are going to do for next 2 hours, so we are going to discuss few case scenarios in common respiratory and CVS conditions, and then we'll discuss further. Right. So I want all you to talk. So this is not a lecture. This is sort of a discussion of the clinical scenarios. Right. So this is our first case. So anyone can volunteer and then we can discuss this.
Madam, I can volunteer.
Is it Sujan?
Yes, madam.
All right. So Sujan, let's first discuss the history. So just analyze this scenario with your, key words, and then just tell us what you understood from this case.
Madam, can I read it now?
Of course.
A previously well 9-month-old baby presents with horizontal symptom for 3 days and worsening dyspnea for 1 day duration. He has low-grade fever. He has not fed well over last 24 hours and passed urine only twice. On examination, he is noted to have oxygen saturation of 89% in air. His respiratory rate is 65 per minute. Heart rate is 120. And he has got intercostal and subcostal recession. Auscultation reveals bilateral crepitation and bronchi. His liver is palpated 2 centimeters below the costal margin and upper border is at the 6th intercostal space. Heart sounds are normal. Give 2 differential diagnoses for his presentation, madam. That's the first question.
So what did you understand from this case scenario? So what did you think as the key factors or keywords in this history, Sujay?
Madam, this is the infection first, and this is located in the respiratory tract, related with the respiratory system. And according to the history, there are several the vital parameters has been given. One, the saturation is low in the air, that is 89, madam, and the respiratory rate also quite high. And heart rate is normal, madam, for this age, 9 months. And same time, in the inspection, the child got intercostal and subcostal recession also. And the liver is pushed down, madam. So these are the key words in the history.
Anything in the first para that you think is important? So you talked about the second paragraph. So
yeah, madam. The presentation, the horizontal symptom for 3 days and worsening dyspnea for 1 day duration, madam, and the fever also. And same time, urine output also less, madam, for the last 24 hours.
Okay, yeah, that's a very important thing. As you can see, he has not fed well. All right. So, continue, Sujan.
So, okay. Madam, the differential diagnosis, madam, this is previously child got upper respiratory tract infection followed by lower respiratory tract infection. Could it be, madam?
Okay, so the first question we ask you 2 differential diagnoses for his presentation. So, what would you take as the differential diagnosis here, Sujan? So that's a 9-month-old coming with some paralysis symptoms and worsening dyspnea, and you have been given some examination findings.
So madam, it could be the viral pneumonia one. Other madam, could it be asthma also, because bronchi also there, and the liver also pushed down liver also. So the hyperinflation, it says.
All right. So others in the group. So are you agree with Sujan, or do you have any other thoughts? So he said his first DD is viral pneumonia or pneumonitis. Okay, and the second one is asthma. So what do you think? Are you all agree with that?
Madam, what about bronchiolitis?
Yes, good. So it could be bronchiolitis. And are you agree with this asthma? Again, Mohammed also said the same. So John, what's the age of this child?
Yes, madam. This is most probably bronchiolitis, madam. Yeah, the presentation similar to asthma, but the age 9 months, so it could be bronchiolitis.
Yes, you know the asthma definition, it says the reversible, airway hyperresponsiveness you need to elicit. So in a 9-month-old, you can't diagnose asthma in the first place. So, but what can be there? So before you diagnose asthma, so what else they can have? Have you heard a condition called viral induced wheeze?
Yes, madam. Viral induced wheeze. Yes.
Yeah, it could be it. So
yeah,
then,
madam. Yes.
So those could be taken as the differentials, right? So first thing, yes, as I think someone Hansel mentioned, so it's bronchiolitis because everything started with coryzal symptoms and then there's worsening of dyspnea. And it could be bronchopneumonia, could be viral or bacterial, as well as viral induced. So anything else that you thought of as the differentials? All right, so let's move on to the next. So who's going to discuss the next part? If no volunteers, I will just call out your names. Is it okay? Or I don't want to do that. So why don't one of you just talk?
So we can do.
Who's this, Buddha? What's your name? Right. Okay. Yes.
Biochemical viral or bacterial involvement where there are these are basic investigation difference. So in that case, by that way,
Hiro, it was not very clear. Can you please repeat it again?
Now, blood investigation so that we can differentiate any infective causes from non-infective causes.
Okay, right. So how would you differentiate with, so what blood investigations you are referring to?
Full blood count, CRP, 2 minutes.
Okay, all right. So how would you differentiate? You're about differentials. So we have already discussed few differentials. So how would you differentiate by doing full blood count, CRP, ESR?
So basically bronchiolitis and bronchiolitis is also infective. So
yes. So if it is bronchiolitis,
viral and bacterial counts more likely to be bacterial.
All right. So if it is bronchiolitis, what would you expect in full blood count, CRP and ESR, the inflammatory markers?
So it's usually respiratory syncytial viral. So it's viral cause. So we don't expect neutrophil to go high. Instead, we might expect lymphocytes.
Yeah, again, at this age, it could be a normal finding. So basically, you won't see any difference, right? So yes, okay. And if it is bacteria, of course, you will see neutrophil leukocytosis and high inflammatory markers. Okay. Anything else you want to do? So we are asking for 3 investigations.
Madam, chest X-ray.
Okay, very good. So who's this? Okay, so tell me, so what would you expect in the X-ray, Puta? So if it is bronchiolitis, what would you see in the chest X-ray? So I can show you X-ray. So who's going to explain this X-ray? So this was taken, this is an X-ray of a child who had bronchiolitis. So who's going to explain this X-ray? What can you see here? So what happens in bronchiolitis? What's the pathophysiology? Lamai. So what would you see in bronchiolitis?
Inflammation of the bronchioles.
Yeah, okay, good. So it's the inflammation of the bronchiole. So what would you expect? So what would you see in the X-ray? So what is this? So what can you see in this X-ray? So because of the inflammation, you will see bronchiolar thickening. So here you can see the peribronchiolar thickening, right? And this is not very clear, but sometimes here you can see the, the more aerated than the other areas. So there can be areas of hyperinflation and atelectasis. There is an atelectasis. So some of the alveoli are collapsed, but some are overinflated. And the other thing is you can see the flattened diaphragm, because sometimes they can have, it's not like bad as asthma, but it's, due to overinflation. So you can see horizontal ribs, and you can see, if you count the numbers, so it's more than 8, and flattened ribs. So you won't see basically anything other than very non-specific findings in bronchiolitis. So whereas in pneumonia, what would you see? If it is a lobe
Consolidation, madam.
yeah, so if it is lobe or bronchopneumonia, so on the other hand, you might see consolidation. So then you should be able to kind of tell at least what are the features you would expect to see in certain conditions. Right. So other test, what is the other test? So I have already shown this. So the other thing is the sputum culture, right? So where in bronchiolitis, most of the time you said it's due to viruses, you won't get any yield. But if it is bronchopneumonia, lobopneumonia, sometimes you might see a positive bacteria. So likewise, you can categorize your investigations. Right. So next thing is the management. So let's say, so this is bronchiolitis. So how would you manage in the next 24 hours?
Excuse me, madam.
Yes. Who's this?
I'm Saishan, madam. Madam,
yes.
In this patient, if it is a bronchiolitis, is the chest X-ray indicated in this child? Do we generally...
No, Buddha, no. That's a very good question. So X-ray is not an investigation you have to do as routine basis. So if that's why we take a good history examination. So if you are sure that this is bronchiolitis, of course, there's no place. But sometimes when you are managing this child, child go into some distress or complications. If this child is not responding as you have expected, so then in those scenarios you can ask, but otherwise you are not supposed to take X-rays for single bronchitis. But of course, you should know what are the changes.
Madam, also, madam, that that horizontal ribs in this age, in normal people, also in children at 9 or 6 months, is it common, or can we say it as a specific?
It's not common, Saishan. Usually, we don't see the horizontal ribs. So the main thing. it's not the only sign. It's not a common thing to have horizontal ribs, but it's the combination of everything. Areas of atelectasis. Most of the time, you might see peribronchial thickening, other than anything else. But of course, this side has some hyperinflation with the shifting of liver. So then this child can have that finding if you do an X-ray. That's why I have put that X-ray to just show you how to interpret your clinical signs with the actual pathophysiology.
Okay, madam.
Okay, Saisha. Yeah. So let's discuss on the management. So here the question is outline the management. So who's going to do that? මට දැන් නම් කියන එක ලේසි වගේ. Janani? So how you would manage this baby? Anyone? There are two Jananis, Janani Rugal Bandar and Janani Jaisingh. Lama, this is for you to talk, right? So if you talk only, we are going to learn. Otherwise, it's not a learning exercise. So let's ask about Mitushan. So tell me the management, Mitushan.
Yes, madam. Initially, since the patient's saturation is 89, we have to stabilize the baby with the oxygen given. And after then the patient's hydration, we have to assess, madam, since she was
Mitushan,
the baby.
Can I interject? So you have to give clear answers. So how would you give oxygen? How much you give?
Since we are suspecting bronchiolitis, madam, in this patient we can give a high flow humidified nasal oxygen.
Mm-hmm. So in the ward setup, would you straight away start high flow humidified oxygen? Have you seen how long usually it takes for us to arrange that machine? So it will take at least 30 minutes, 20 to 30 minutes for us to prepare that machine. So till that time, what would you do? Saturation is 89%.
Then
what would you do then?
Then we can connect it directly to the oxygen, madam. And
so how would you connect directly to the oxygen?
We can give like 2 to 4 liters per minute, madam.
Okay, what is oxygen delivering device? This is a 9-month-old. So what would you use?
We can use face mask. Yeah.
Okay, Lama, have you seen the face mask? Those who have already done this pediatric appointment, have you seen small mask specials for small mask for small babies, or do we have the same mask for everyone in the ward? So this is a 9-month-old. Do you think they will keep the face mask?
Nasal prongs.
Yes, nasal cannula, nasal prongs, right? So it will provide a flow as well. So when you're answering the question, so you should give specific answers. It's not like just giving oxygen. So you have to say, what is the oxygen delivering device and how much you are going to send, right? So if you complete the answer, Mitushan, so how would you give oxygen?
We have to initially give the oxygen via nasal prongs. The oxygen will be 2 to 4 liters per minute.
Okay.
We can start initially and
failing that?
And failing that, we can increase the rate, madam.
What's the maximum you can give by the nasal cannula?
6 liters?
No, 4 liters. So you can't go beyond 4 liters. So then what is the next option?
We can use.
You already told us. No. High flow.
High flow nasal. Yeah, nasal oxygen. Yeah.
All right. So you have to say, okay, you start with the low flow nasal cannula oxygen 2 to 4 liters per minute. And failing that, you would think of starting high flow nasal cannula oxygen. All right. So what else? So steps in the management. What else you need to do? So where would you keep this child? So you are seeing this child as a house officer. So you have to think as a so you are the house officer seeing this child. So where would you keep this Baba in the ward?
I will keep this baby in the emergency room, madam. B room.
Yeah. So that's also important. That's also part of your management. So you should understand this is a sick baby. So you are going to keep this baby under close observation. So sending this child to the E room or high dependency unit should be one of your management steps. And then you start oxygen. Or you can start oxygen first and you can send this Baba to the E room. Okay, what else you have to do?
Then I have to connect the child to the cardiac monitors and respiratory monitors for the close monitoring.
Okay. Mm-hmm.
And madam,
what are the monitoring parameters? What would you monitor in this time? What parameters would you monitor?
The saturation,
Okay.
the respiratory, and the heart rate as well as blood pressure also we can monitor.
Sometimes it's not very practical for us to check blood pressures because they are very unpredictable. Okay. Right. Right. So what else you would do?
And the child was not fed well over last 24 hours, madam.
Outline the management. Sorry, Putta, I didn't catch you.
Since, madam, the child was not fed for last 24 hours, I have to check for the dehydration of the child and hydrate the child.
Okay, how would you hydrate now? Definitely. So this Baba has passed urine only twice. So it's not adequate. So how would you hydrate?
It depends on the dehydration status of the patient, the baby, madam. Whether if it is in a some hydration or severe dehydration, or if it is severe dehydration, we can go for intravenous fluid therapy. Otherwise, we can ask to continue with the breastfeeding. And complete since 9 months.
Others, are you happy?
No, madam, oral feeding is not possible in this baby, madam.
Yeah, just see, Putta, the respiratory rate is 65. Baba is having intercostal and subcostal recession. Would you think it's a good idea for you to continue breastfeeding in this baby?
No, madam.
No, so this Baba is having moderate to severe distress. So then, what is the other option you have? So how would you feed this baby? Of course, you have to feed, but it's risky to offer the breast or to give oral feeds. So then what can you do? What are the other alternative feeding methods we have?
NG feeding, madam.
Yeah, good. So either you can start NG, what is the other option? Or you can start IV fluids if the child is really sick. So sometimes by giving NG, it can, inflate your stomach and can cause aspiration. So for short term, you can give IV fluids. Right. So your management should be specific for this particular child. So giving oral feed is not the case here. Okay. Anything else? Anything else for the management?
Madam, can we nebulize that?
Okay, good point, Putta. So what do you think? So that's why I have asked for the pathophysiology. Is there a place for, so nebulize with what?
Ipratropium, madam.
Okay, then what is ipratropium, Putta? What is hypertrophy? What's the mechanism of action? Anyone? What does it do?
Madam, since the hypertrophium and salbutamol are acting against the bronchospasm, in bronchiolitis, mainly the problem is inflammation. Is it not very useful?
Yes, so that's correct. So in bronchiolitis and asthma, the pathophysiology is completely different. So in asthma, you see airway hyperresponsiveness and bronchospasm. So if you give a bronchodilator, it will work. But on the other hand, bronchiolitis, you basically have the inflamed mucosa, and as a result, they produce lots of mucus. And they have lots of secretions, and it can block your bronchioles and cause disturbed respiration. So by giving a bronchodilator, it won't help with that. So recommendation for bronchiolitis, there's no place for any sort of bronchodilators. But if you see a child with strong history of atopy, and having eczema and mother having a strong family history of asthma, you might try. But for pure and simple bronchiolitis, there's no place for nebulization. Is it clear? What else you can do in the management?
Madam, excuse me. Since we are thinking of viral induced wheezing also, can we go for nebulization?
Yes, Puta Mama. So Metana, so when you look at the history, so from the history, it's more towards bronchiolitis. Yes, you can try, no harm. But I have prepared this history thinking of a bronchiolitis. The predominant component is the crepitations and bronchi, and then the history is very short lasting, and I have not given you any clue because to think this as viral induced wheeze. But yes, as you said, you can give a trial and see. But if it is pure bronchiolitis, which is a clinical diagnosis, there's no place for nebulization.
Okay.
Madam, what about hypertonic saline nebulization?
Yes, Puta, in the past, when I was a registrar, so we were used to use hypertonic saline because by nebulizing with hypertonic saline, it used to drag out the liquids from the epithelial cells, and it can liquefy the mucus. That was the understanding. But according to the latest guidelines, they are not recommending. But sometimes we nebulize with 0.9% saline just to kind of relieve the obstruction, but no evidence behind. So basically, it's the supportive management in bronchiolitis you have to do. What else in the management you have to discuss? So budesonide, again, Putara steroid. So Kitwini is asking whether we can nebulize with budesonide. So it's good for laryngotracheobronchitis, like true. Yes, you can. But here the problem is in the bronchioles. It's not in the larynx or trachea. So by giving budesonide, it will not work. So there's no place for budesonide. What else you have to do? Just normal. Again, adrenaline is same. So adrenaline, it's usually be nebulized with adrenaline if there is impending respiratory arrest. So idea of nebulize with adrenaline is to cause immediate vasoconstriction so that it will reduce the edema, so that you will buy some time till you prepare for your intubation or till you do any intervention. So adrenaline nebulization we don't recommend. In severe croup or severe anaphylaxis, we nebulize with adrenaline, but not in bronchiolitis. There's no place. I hope I have answered your question here. Right, so what else you can do for the management? Small things. What else? So this Baba was having some fever, right? So calming and making this child comfortable also is important because they are very irritable. So because of the irritability, they can start crying and it can worsen the respiratory distress. So you can give some antipyretics and you can calm them down, right? What are the other steps in the management?
Madam, what about antihistamine in the horizontal symptom, because child has this horizontal symptom?
Yeah.
So antihistamine, madam?
Again, for the antihistamines, yes, I know that we give, but it doesn't give a clear effect. So what the latest evidence recommend? So nothing will work against bronchiolitis. So antihistamine we give for children who having any atopic background. It's like for allergic rhinitis and atopic, it will work because it's an IgE mediated pathway. But here it's due to a virus. So ideally and scientifically, they have proven that there's no place. So again, it's out. What else? Management is a broad term. So what else you have to do in the management? What would you think about the mother? Don't you think we need to counsel the mother?
We have to reassure the mother.
Yes. So always that should come under your management, counseling and educating the mother and giving information. So when you are describing the management, you should always include that part as well. So of course, a 9-month-old, if the child needing oxygen, mother should be very devastated, right? So always you need to address the anxiety of the mother as well. And Sairuban is asking place for antibiotics. No. For pre-bronchiolitis, we don't give any antibiotic. But if it is going beyond 1 week, and if there is any evidence of secondary bacterial infection like onset of high-grade fever and long-lasting cough, then you have to think of giving a course of antibiotic for the possibility of secondary bacterial infection. But otherwise, pure bronchiolitis, no place for antibiotics. And again, breastfeeding, depending on the respiratory distress. So here, this child is moderate to severely distressed. So it's not a good option. But if the child is, the distress is settling, of course, you can restart breastfeeding, or you can express and give it via a tube. So those are the options you can do. Right. So any other questions? Yes, prop up. Yes, Puta, one thing, 9 months. So yes, by propping up, the idea is by the diaphragm, it will help the diaphragmatic movements. So yes, you can prop up the child. That will help to breathe. So that's how you should be talking about management. So you have to address each step, including the monitoring, the giving oxygen, feeding, counseling, admitting, blah, blah, blah. Everything should be included. Right. Any questions? Right. So we'll move on to the next case. So who's going to discuss this one?
Madam, small doubt, madam.
Yes.
Can viral-induced wheezing cause crepitations?
Yes, Putta. So what happens is, again, viral-induced wheeze, bronchiolitis, everything due to infection. Most probably it's due to viruses. So what happens is they can produce some mucus, and when the alveoli fill with secretions, so you will hear crepitations. But predominantly you will hear bronchospasms. But sometimes you might hear crackles due to that reason. So it's not an uncommon finding.
Okay, ma'am. Thank you.
Okay. Any other questions on bronch?
Madam, from the CRP also, we can differentiate between viral and bacterial?
Yes, Putta, but again, some viruses like adenovirus, it's known to cause high CRP, but most of the time, yes, the common, in a common practice, you won't expect any CRP rise. But medicine, it's not always 100%. So sometimes in some viruses like adeno, you might see high CRP. And other thing is, one after another, bronchiolitis complicated with secondary infection, again you might see high CRP, but pure bronchiolitis you won't see most of the time.
Okay, madam. Thank you.
Any other questions, or shall we move on to this case? So who's going to discuss this one? ළමයි අපිට cases ගොඩක් තියෙනවා discuss කරන්න, so you have to do it quickly. Pete's group එකේ Rehani discuss this case. Start.
An 8-year-old boy is admitted with a history of fever and cough for 7 days, taken treatment from the GP twice, and admitted to the hospital as he became breathless and had no response to treatment. What is the diagnosis or differential diagnosis? So this could be, since it's 7 days, it can be a bronchopneumonia, madam, or lobar pneumonia.
All right.
So list 3 symptoms and signs you would expect to see in this child. So the symptoms, I have to see if the cough is productive and whether it's purulent. And also whether the child is feeling breathless. And whether we should ask whether the child is making any noise when he's breathing.
Okay. Like
And
what?
the sign, any wheezing noises, madam, and
grunting noises. Okay.
grunting noises. And the signs, madam.
Sorry, Rehani, anything else other than the things you have mentioned? So what are the other symptoms they can have? Others? Anyone can answer.
Extra pulmonary symptoms we have to ask here.
Like what?
Like, for example, like atypical pneumonia, such as headache, diarrhea,
Okay.
arthralgia, those features also.
All right.
Because that is common more than 5 years.
Yeah. Okay. Yes. What else? What else they can have?
Madam, you asked me,
What else in the history?
Madam, whether the fever was high fever and associated with chills and rigors?
All right. Okay. What does that suggest if there is fever and fever with chills and rigors?
It would suggest pneumonia.
Yeah, I mean, if there's ongoing, yes, pneumonia with a complication, right? So because sort of pyogenic.
Any chest pain, madam?
Yeah, good. So what sort of chest pain would you expect them to have?
Pleuritic chest pain?
Yeah, pleuritic chest pain. So, but what's the commonest complaint of children? Would they complain of pleuritic chest pain? It's usually the adults in medicine you will see that, but what would you see in children? Most of the time they will have a referred pain to the abdomen. So most of them they can complain of abdominal pain, but actually it's a referred pain, right? So so that's why when you see a child with abdominal pain, so lobar pneumonia should be one of your differentials. So it could be other way around as well. Could be a referred pain. All right. What else in the history you need to ask?
Madam, the mother may have noticed rapid breathing of the child.
Okay. Yes. Yes. What else? Breathing.
I mean, are the family members having a fever or past because it's a viral?
Yeah, contact history, that's important. And whether this child is going to school, 8 years, so, but these days they don't go. But if they are schooling, you need to ask. It's possibility of a contact. Anything else? How is the feeding? You know, the common things. So they will not feed, and how is the physical activity, so whether they are playing or whether they are lethargic, staying in the bed. So it will tell you the severity of this illness. Usually children, they won't stay still unless they have a major problem. So it will tell you, okay, this is really bad, right? Okay, so what are the signs?
Whether child is in respiratory distress, madam, any nasal flaring, intercostal, subcostal recessions, and whether the child is tachypnic.
Okay, so the respiratory distress with the usage of accessory muscles and the respiratory rate, increased respiratory rate. Okay, good. What else, Putta?
And on the respiratory system examination, madam, whether there is any whether there is any reduced chest movements on any specific area, suggestive of lobe pneumonia, and whether there is dullness to percussion and the chest movements are reduced, and also whether there are any crepitations and bronchial breathing.
Okay, good. Anything else?
Reduced air entry, madam.
I can't hear you.
Reduced air entry?
Yes, reduced air entry. So it could be bronchial breathing or could be vesicular breathing with reduced intensity. Right, what else? So you said the percussion note is dull. Is it always dull? What are the other possibilities?
Madam, it can be stony dull in the presence of an effusion.
Yes, so there can be associated pneumonic effusion as well. So in that case, you might expect a stony dullness, right? So anything in the general examination? Any other signs? Again, you can look for, additional sounds like, the grunting, and in extreme cases, you might see cyanosis. So likewise, so you should be able to categorize the symptoms and signs. So these you should expect to elicit in your, history taking as well. Right, okay. So then, how would you manage? So this is your case scenario. So how would you manage this child? Again, list out the steps in the management. So when you talk about management, what does that contain? What does that consist of?
Investigation and treatment.
Yeah, good. So it should include investigations and treatment. Okay. So then what investigations would you do in this child?
So the same 3 investigations we did in bronchiolitis, but expecting different results. Like full blood count, we would expect to have high neutrophil levels, and chest X-ray, we would expect to see a consolidation. And the other one was, such.
Okay, so you would do blood investigations as well as radiological investigations. So depending on the etiology, you might see different findings, right? So again, yes, as you said, so we can again do blood cultures, sputum cultures, so inflammatory markers. But if it is ongoing, but not this child, you have different, tests like tuberculosis, you have to look for the others as well. All right. So suppose this is a chest X-ray of this particular child. So who's going to describe this X-ray? Anyone? So you are supposed to interpret X-rays, right? So you should be able
Madam, there is a right-sided upper lobe
heterogeneous opacity, madam.
Okay.
And the trachea is in the midline, and but there are no air bronchogram in the upper zone.
There are air bronchogram. Like this. Okay.
Yeah.
And what else?
And there are no, if you, then.
Okay, you are trying to tell this meniscia clear, so it's
clear, yeah. No associated effusions are there.
Okay, what is this? What do you call this? Anatomy?
That's a fissure.
Yeah, this is a horizontal fissure. So what happened to that horizontal fissure? It has gone out.
Yeah, it's gone out.
Okay, so what is this? Then what is the clinical diagnosis?
The right upper lobe consolidation, madam.
Okay, so the clinical diagnosis is consolidation, right upper lobe pneumonia without any complications. Okay, so who's going to describe this X-ray? Let's say this is not from the same child. So this Baba is around 13 months. So when you're looking at an X-ray, just either you can start from periphery and come to the middle, or start from the middle and go to the periphery, whatever you are prepared to do. So look at the lung base, you know that the lungs, look at the cardiac shadow, and then look at the bones, soft tissues, so likewise. So who's going to explain this X-ray? Anyone? So what is the problem here? So any problem in the heart, cardiac border? Any problem in the lung bases or lung phase? Are you all agree there's something here? So is this a normal finding or what is this? That's why I specifically told you the age. I told this is the X-ray of a 13-month-old. Actually, this is a thymus. So we call this as a sale sign. So you know in sales, so it's like a Walnavakian, so it's the same sign. So till up to 2 years, your thymus is a little bit bigger, but later in your life, it gets shrunk. So when you do X-ray, sometimes you might see the thymus, which is not a consolidation. Just I wanted to highlight this is a normal finding, right? So this is not a consolidation. If you see something like this, so it's the thymus. It can come from the other side as well. Is it clear? So this is just a normal finding. Okay. So explain this X-ray. What you can see here. So left side, do you see anything? So there's some... Yes, Puta? Yeah, tell me. What do you see here? What can you see? So here some peribronchial thickening is there, but you can't see homogeneous opacification on the left side. But what about the right side? So what is this area? What is the anatomical area of this opacification? Which part of the right lung you can see this?
Middle lobe. Middle lobe?
Yeah, very good. Why did you say it's middle lobe?
I can see the horizontal line above which is the horizontal fissure. And
basically Putta, because it has obliterated the right heart border. So usually if it has obliterated the right heart border, so it's the middle lobe. As you can see, you can nicely see the diaphragm. So it's definitely not the lower lobe. And horizontal fissure is somewhere here. So it's kind of, so if you take a lateral X-ray, you can see it like a wedge, this part. So it's, so what is the underlying problem here? It's the right mid-lobe consolidation. So it's a right mid-lobe pneumonia because you can't see the right heart border. Okay. So what is this? It's not a very good quality X-ray, but still you can see. So what can you see?
It's right lower lobe pneumonia.
Okay, yes. Can this be an effusion? How to differentiate a consolidation from an effusion?
Effusion would be, madam, homogeneously opaced.
Yeah, homogeneous opacification. And the other thing is?
The meniscus level will be there.
Yeah, meniscus level will be there. And in a consolidation?
It will be a heterogeneous opacity.
Mm-hmm.
And air bronchogram can be there.
Yeah, you will see air bronchograms. So this is a, actually, as you said, right lower lobe. So where you can see clearly the right heart border, and then it's arising from the right diaphragm. Right. Okay. What is this? So right side. Sorry, Putta, yes.
Hyperinflated lung, madam.
Sorry, I didn't get you. I didn't catch you.
Hyperinflated lung, madam.
Okay, all right. Oh, yeah, by looking at it, you can see it's hyperinflated. Yes, anything else? Actually, you need to, you should be able to count the ribs, but I agree that it's not a very good, thing. What else? Do you see any abnormality on the right side? Anything on the left side?
Is it a right side pneumothorax or something like that? Because I can see the right heart border. Right heart border is not there. It's more like blackish color.
Okay, you can see our bronchograms here, right? So they are going up to the pleura. So there's no, the lung is there. No,
the lungs are more radial use, madam. There may be air trapping.
Okay, yes, hyperinflation is there, I agree. What else? How many more lobes we have now? So we talked about right upper border, right middle lobe, right lower lobe. What else you have? Common sense. Now, which are the lobes then? So what do you see behind the heart? So what is this? This straight line. This you see usually due to left lower lobe consolidation. Usually left lower lobe consolidation. Usually you see the, silau behind the heart. So, api dakinne mehema collapse wedge ekak. So this is a straight line. So this is the collapse part. So this is the consolidated lobe. So this is the cardiac shadow. So this is the X-ray of a left lower lobe pneumonia. Understood? So you can just Google and see how you would look. But this is exactly how would you see in a left lower lobe consolidation. So what is this? Again, any infection lamai, there can be some peribronchial, flare up. So in both hili region, so you might see bronchioles and vasculation. So don't worry. Most of the infections, you will see that. But apart from that, what else you can see here?
Madam, left heart border is not clear, madam.
Okay, good. So it's like this area is obliterated, right? So what would you see what would you find in this area?
As you said, left lower lobe.
Anatomy. So what do you call that lobe?
Lingula of the left side.
It's a lingular. So this is what you would see if there's a pneumonia in your lingular lobe. So like a wedge, and you won't see the left heart border. So this is lingular lobe. So I just wanted to kind of highlight few X-rays, so then because these things could be questioned in your IOPs, right? Okay. So we talked about the investigations, and then you need to talk about the treatment. So what would you do? How would you treat this child? So I will put the case scenario. So this is the case. So how would you treat? Quickly. So list out the principles of management.
Yes, madam. We have to treat the underlying problem here. Here the fever is going with the underlying lung pathology. So first we have to treat the fever and underlying lung pathology with the antibiotic, madam. So initially we can start empirical antibiotic until the culture arrives, more specifically.
Okay, so what empirical antibiotic you would start in this child?
So, madam, we can start as the patient is up to 5 years. The choice would be clarithromycin, or azithromycin.
Okay, so why you want to start a macrolide here?
Because, madam, this mycoplasma pneumonia is common in the up to 5 years.
Okay.
But no. You showed the X-ray, madam. So in the X-ray, that is lower lobe pneumonia. So we can expect we can combine it with, madam, penicillin also.
Okay, so what are the other organisms? So this is, I agree, this is a community-acquired pneumonia. Are you all agree? So this Baba came from home. So it's a community-acquired. So, Jan, you said one organism is mycoplasma. What are the other causative organisms for community-acquired pneumonia in this age group, other than mycoplasma?
Streptococcus pneumoniae.
Yes, very good. So other common thing is strep pneumonia. What else? What else?
Staph aureus.
Yes, not very common. Yes, still you can get infections due to staph.
Klebsiella.
Klebsiella you will see in smaller age, but yes, I can't say wrong. And the other thing is I think one of you mentioned chlamydia. So those are the possible organisms. Right. So yes, you can start a macrolide. Anything else you want to, because this Baba received treatment twice from a GP. So then, and then again, despite that, became breathless. And come into the hospital. So what else you would do here?
So, madam, the antibiotic didn't respond. So there may be several reasons, madam. One, the resistance. Other one, madam, there may be complications such as the empyema. But anyway, the X-ray didn't show it.
So what would you start? Now you're the house officer and you have classed this patient. So how would you put your management? So are you only starting macrolide or do you want to add something else?
Yes, madam. I want to add amoxicillin or cefotaxime dose antibiotic, madam. Cephalosporin, third generation of cephalosporin, I will recommend.
Okay, so you want to start with third generation cephalosporin. Okay. Anything else you would do in the management? Other than starting antibiotics, what else you have to do?
Madam, since the patient is coming with a breathlessness, can we go for an ABC approach in this child?
Yes.
So, I will look for the saturation of this patient initially since he is having breathlessness. And if the saturation is less than around 92, we can go for oxygen therapy. And since the child is ill, we can go for IV access in this child for the above investigations. And if needed, if the patient is not tolerating any oral or if he is severely ill, since he is breathlessness and things, and we can go for IV antibiotic along with, as Sujan said, like we can go for the fever management and go for the antibiotic treatment, ensuring that hydration is maintained.
Okay. So when you ask to kind of list or outline things, you should be able to kind of list out the things as I think Sanishan mentioned. Right. So you have managed this child. Again, the basic things like propping up, keeping the child under continuous monitoring because this child is breathless. So counseling parents, giving oxygen, nutrition, chest physio. So you have to address everything, right? So everything should include in your treatment. So then you have started, let's say, cefotaxime and oral clarithromycin, and after 48 hours, still child is unwell and there are fever spikes and he's dizzy. So what are the possibilities here?
Dose of the antibiotic might be a problem, or choice of the antibiotic, whether is there any resistance to the chosen antibiotic.
It could be any abscess or some sort of hidden source of bacteria which keeps the child in continuous.
There can be resistance.
Yes, so you said one said there could be resistance to antibiotics, right? Yes. And another one said there could be a complication. All right. So what are the other possibilities?
Empyema or abscess formation?
Yes, empyema abscess, local complication. Yes, what else?
The antibiotic cannot cover the particular organism.
Yes, good. So, what else?
Hospital-acquired infection.
Putta, now here, the same fever is going on, right? So, yes, could be a hospital-acquired, some other infection. Yes, okay, taken. What else? As a house officer, what are the other factors you need to look at? The simple things?
Dose of the antibiotic, madam?
Yeah, very good. So just see. Just see with those. So it could be a resistant organism. That's why you need to chase your cultures if you haven't done it, and then you might need to change, and then there could be a complication. So then you have to think those possibilities. Or as one mentioned, could be a second hospital-acquired infection as well. All right. So so what would you do? So as you said, the complications. So then obviously you might do other than chasing your report. So you can do an X-ray. So this is the X-ray you have seen. So who's going to explain this X-ray? What can you see here?
Right-sided pleural effusion.
Yeah, very good. So why do you think it's a pleural effusion, Putta? Why it's not a consolidation?
There is homogeneous opacification as well as the meniscus.
Yes, okay. There's homogeneous opacification. I think all of you can agree because we can't see any AR bronchograms here like here. So it's a pleural effusion. So what do you call this pleural effusion? It's a pneumonic effusion, right? Yes, so there can be a lobar pneumonia causing effusion, right? So if the child is not responding, this is you might need to do an X-ray, and this is another X-ray. So what can you see here?
There is a right upper slope cavity with the fluid level, madam.
Yes. So there's a fluid level.
Abscess.
And it's, as you can see, it's an abscess. So you might see something like this. Or what is this?
Right-sided pneumothorax.
Okay. So why do you think it's pneumothorax?
Because the right-sided lung pushed towards the mediastinum, and there is a hyperradiolucency in the periphery.
Good. So you can see the lung border clearly, and then you can see the hyperlucency. And when you talk about pneumothorax, you always need to see whether this is a tension pneumothorax or not. So what do you think?
The trachea also deviated to the left side. So
Trachea is deviated. So this is a pneumothorax.
Yes.
So in which conditions would you see a pneumothorax? In infections? Out of the organisms you have listed before, so which is known to cause pneumothorax? Usually the Staphylococcus. They are known to cause pneumatoceles and they can rupture and cause pneumothorax. So if you see something, if a child is not responding to your usual treatment, so always you need to look for the complications while you are looking for the other factors as well. Right. So any questions?
Madam, what's the difference between synpneumonic effusion and parapneumonic effusion?
So parapneumonic කියන්නේ පුතා usually malignancy වලට it's not like the differentiation between transudate and exudate. So it's like due to as a reaction you might sometimes get a effusion. So there are in TB, in primary TB, you will see a effusion that's actually not due to the infection itself. It's due to the immunogenicity. So like that.
Okay,
that's the understanding.
Okay, thank you, madam.
That's what you see pneumonic and parapneumonic. What else you can do other than X-ray? What are the other investigations you can do at this point? If a child is not responding, what else you can do?
Madam, the endoscopy such as bronchoscopy can we do?
Okay, as a last resort, yes, if you see any sort of a collapse, yes, you might do a bronchoscopy and you
An ultrasound we can do,
might get a bronchoalveolar lavage, all right? But
an ultrasound scan?
Sound scan. So if you see a pleural effusion, you can do an ultrasound scan and of the chest. You can see whether it's a collection, what sort of effusion is. What else you can? What are the other tests you can do? Yes, ultrasound scan of the chest. What else?
We can aspirate the fluid for diagnostic purpose, madam, whether it is the empyema or...
Yes. Okay, you can do a diagnostic test to see the organisms and to send the microbiology, cytology. Yes. What else?
Can we do Manto in this patient since it's like complicated one, thinking of a TB?
Yes. If the, yes, because Sri Lanka is a highly prevalent country. We have tuberculosis. So because you are covering with antibiotics, but despite that, you are having fever, yes, you have to think about the other causes, possibilities like tuberculosis. Yes. What else? How would you test for TB?
We can do the Manto test, madam, or otherwise we can get a this sputum for the acid-fast bacilli microscopy and culture.
Okay, how would you send this sputum? How many samples you need to send?
3 samples consecutively, early morning samples.
Okay. In a small baby, how would you take
Gastric aspirate, madam?
this sputum sample? Yes, it's the gastric aspirates because it's not, they are not able to produce sputum. So in that case, you have to get the early morning gastric aspirates in small babies, but otherwise the early morning sputum samples. Right. Okay. Anything else you want to do here? Any other test? Would you like to repeat your cultures, inflammatory markers, and see what is the trend, whether it's rising, static, or whether it's improving? So you can repeat your, bloods and see. And in the meantime, you can optimize your antibiotics. You can kind of optimize and see. So that's how you manage. Any questions you have on that? Okay, then shall we move on to this? So this is a simple case. So who's going to discuss this one? Quickly, Lamai, who's going to discuss this question? Vishwa, would you like to discuss this question?
Madam, we can see how the child is whether the child is tachypnic or normally breathing, whether the child is agitated, drowsy, or are there any signs of cyanosis? And objectively, like we can use assessment of oxygen saturation SpO2, whether it's less than 92 or above 92.
Okay. So what are the main classification of severe Rikputa?
Mild, moderate, severe, and light respiratory.
Okay. So that is the classification. So this is what you would see on assessment. So tell me, how would you categorize this distress?
I think it's severe, madam, because we go for the maximum, at least in any of the parameters that we have discussed about. So here, SpO2 is around 90%, so which is less than 90. So that falls in the category of severe asthma. whereas less than 89 is life-threatening. So, whereas
yes, good. So as you can see, according to the categorization, so it's definitely not life-threatening and doesn't come under moderate as well. So it's severe as well. Right. Okay. Good. So how would you manage? So within next 6 hours, how would you manage this child? So this child is having acute severe asthma. So steps in the management.
So this is also an emergency, madam. So we will be following an ABC approach according to the ATLS protocol. Then we will start the patient on high flow oxygen along with 100% oxygen along with nebulization with salbutamol, madam.
Can I interject, Puta? How would you give high flow 100% oxygen?
By face mask.
How
madam.
would you give? Okay, but how much you would give from the regulator? Is it possible for us to give 100% oxygen in the ward?
No, we can't give 100% oxygen, madam. Sorry. It's like we give about 6 liters.
Unless you have a rebreathing mask or a ventilator mask, you can't.
Yeah.
Yes.
So we'll give about 6 liters. If we are using a face mask, we'll give 6 liters of oxygen. Along with it, we will be giving salbutamol nebulization 3 success, one after the other. If the child is not responding, we will start. We will give salbutamol along with ipratropium. But since it's severe in category, we can straight away. I think.
Right. So you said it's you are going to start 6 liters, right? What?
Yes, madam.
So why 6 liters?
Because that's the
why you are so stingy on oxygen? So this papa is having severe.
No, I thought that.
What do you call high flow oxygen? No, maximum is 15.
No, with that setup, but
so
it's only with the nasal probe.
Means 8 to 15 liters.
But with the face mask,
yes.
I think we can give 10.
Obviously, so when you calculate the FiO2 with a flow of 4 liters, you can give at least 30% of FiO2 if you are using nasal cannula. So nasal cannula is out here, right? So you have to go for higher oxygen saturation. So to achieve that, you have to go for the face mask. Again, you should not be giving very low dose, like 5 liters. So you have to go for a high, at least 10 to 15 liters per minute, right? So you have to say this is acute severe asthma. You would start oxygen via face mask, high flow, 10 to 15 liters per minute. So let's say 10, right? Right. Okay. So what do you do next? Did I confuse you? Lamai, what would you do next? So what happens in asthma?
Bronchospasm, madam.
Okay.
And inflammation also.
So how would you address that problem?
So, madam, initially we have to nebulize, as this is a acute severe asthma. We have to go with ipratropium and salbutamol. As the age is more than 5 years, we will go 1 milli of ipratropium plus 1 milli of salbutamol mixed with 2 milli of normal saline, madam. We have to nebulize back-to-back nebulization 20 minutes over the 60 minutes. And meanwhile, we have to start prednisolone also, 1 to 2 milligram per kilogram prednisolone, madam. We have to start it. But we may go with IV hydrocortisone. Sorry, madam. And here, madam.
In what instances would you go for IV hydrocortisone?
If the child is unable to take it orally, or if very severely ill child, madam, because efficacy is same.
Yeah. If the child can take oral, still you can give oral prednisolone.
Yeah,
but
oral.
if not, you can go
If
for
not, madam, IV hydrocortisone, 100 milligrams, 6-7 madam, I may give. So I have to wait
4
for the
milligrams
response, but
all right. Right. So what else in the management? How would you position this child?
We have to keep the child in a proper position, madam.
That's very important, Lamai. Which area of the ward you keep this baba, right? Positioning, oxygen. So you have to list all the steps. So that all carry marks when you are answering a question, right? Okay, what else?
If the child is not responding to the nebulization with salbutamol, madam, we may go for the second line drugs.
All right. Good. So in the meantime, you need to reassess and then see, okay, this baba is not responding. So what would you do next? So you have given back-to-back salbutamol and you have started steroids, but still the condition is same.
We may go for the second line treatment, madam, but still we have to exclude the other pathology also. We have to confirm whether it's asthma or any other pathology.
I can't hear you. Okay. So what would you do next then? Is there a problem with the connection? I can't hear you.
And start the patient on Maxalfate, madam, as a second line option.
All right. Okay. Why Maxalfate? So what are the medications? What are the second line medications you can use in asthma? Yes, you are correct.
So we can use Maxalfate, or we can use salbutamol infusion, or we can use theophylline.
What is the other drug?
Aminophylline, madam.
Okay, good. Aminophylline. All right. So out of these three, what is best?
Magnesium sulfate.
Sorry, Puta, I didn't catch you.
Magnesium sulfate, madam.
I think it's aminophylline, but it has side effects, and that's why we prefer Maxalfate, which has balanced.
Usually, Puta, nothing is superior. So your choice will depend on the availability and the experience of your team, and so that's the main determinant factor. So out of Maxalfate versus IV salbutamol versus aminophylline, you can't say this is superior to the other. So it has its own side effects, but if you are familiar with the drug, if it is freely available, of course you can try, right? So it has the same, same place. So these are the assessment monitoring after 1 hour. So then your next step is you are going to start a second line medication. So let's talk about Maxalfate. So, so what are the problems in Maxalfate?
Maxalfate can give us to hypotension and bradycardia mainly, madam. Those are the side effects.
Yes, it's a vasodilator. So it can cause peripheral vasodilatation as well and causing hypotension. So that's one side effect. And aminophylline?
It causes arrhythmias.
Yes, good. So it has a cardiac toxicity. And what is the question you need to ask before you start giving aminophylline?
Whether the child was on oral aminophylline spray.
Oral theophylline. Yeah, what is the reason for that?
Because if so, we are not going to give the bolus. Otherwise, it has a narrow therapeutic index. We would push the child into the toxic level.
Yeah, that's true. So always you need to make sure that this child was not on theophylline. So as because of the reason he has mentioned, right? So what's the problem with IV salbutamol? What are the side effects?
Normally the expected side effects are, madam, the increased sympathetic activity causes tachycardia and tremors, but the problem is it can cause hyperkalemia as well.
It causes hypokalemia.
Sorry, hypokalemia. Sorry.
Yes. So salbutamol can drag. It will shift extracellular potassium to intracellular. So it will shift potassium from plasma to the cells, causing hypokalemia. Yes, it can cause hypokalemia. So all the medications has its own side effects. So according to your preferable, preference, you can start either. So what happened? So suppose we started this Baba on aminophylline. Was stable for a few hours, but again suddenly became unstable, and his oxygen requirement went up. So what would you do next? So we are talking about this Baba who came with severe asthma. So there's a sudden deterioration in the clinical condition.
So, madam, if there's a sudden deterioration,
like pneumothorax or type 2 respiratory failure.
Okay, good. So what would you do?
For the pneumothorax, we can examine and identify, or if the chest X-ray, we can go for. For the type 2 respiratory failure, we can do AB blood gas analysis and identify.
All right. So as you can see, so here you can see there's a pneumothorax, and those are the things we have to do. We have to do with this. All right. So this is the blood gas. So who's going to analyze this blood gas? So who's going to interpret this?
Madam, in the first hour, there is alkalosis, madam. pH is 7.5. Which can be explained by the decrease in PCO2. So it's a respiratory alkalosis, and bicarb also at 15, which is less. So there is a partial compensation is going on, mostly from renal. So that is a respiratory alkalosis, partial renal compensation. While at 6,
so is it a normal thing or abnormal?
No,
so is this a normal finding or abnormal finding?
No, that's what we do.
So what? Yeah, why this respiratory alkalosis? What is the reason?
Hyperventilation.
Yes, this Baba is tachypneic. So soon after he came, he was tachypneic, and he has washed out all his carbon dioxide, right? So you might find respiratory alkalosis. Okay, what happened after 6 hours?
Now it's an acidosis, madam. That can also again be interpreted, explained by the increased PCO2. There is
sorry, yes, continue. Yeah.
There is a compensation going on in the bicarb level acid, which is high right now. So that is the respiratory acidosis, madam, with partial compensation.
So what do you think the reason? Would you expect this? Is this a normal finding?
It is a type 2 respiratory failure, madam.
Type 2 respiratory failure.
Yeah, very good. So if you see a blood gas like this, so it's not at all normal. So I hope others can understand the interpretation of blood gas. I think you should know the basic, the basics of blood gas analysis. So first look at the pH. just determine whether it's acidotic or alkalotic, and then look at the culprit, whether it's due to respiratory, carbon dioxide, or whether it's due to metabolic, bicarb. So here, as you can see, its carbon dioxide is low. So this alkalosis is due to low carbon dioxide, whereas the other side, so there's acidosis and it's due to high carbon dioxide. So vice versa, you can interpret for metabolic. Yes. So we did this, and then there's carbon dioxide retention. So one thing is type 2 metabolic, type 2 respiratory failure, and the other, what is the other sorry, Lama, what is the other possibility? So if you see a carbon dioxide retention, so what is the other possibility? Can you hear me now?
Yes, madam, but we can't see your screen.
That's okay, Puta ma'am. Just give me 2 minutes. So till that time, tell me what can happen if there is accumulation of carbon dioxide. So what are the other possibilities?
Madam, IV salbutamol, if we give, sometimes VQ mismatch can occur. So because of that?
If you give IV salbutamol, what metabolic abnormality you expect? What would you expect in your ABC? Usually, it can cause lactic acidosis. So you will see a metabolic acidosis. BQ mismatch, purely due to salbutamol, it's unlikely, Puta. Yes, you are correct. It's due to BQ mismatch. Carbon dioxide is not washing out. So what is the reason? There has to be some obliteration. Other thing is pneumothorax. So that is the other thing you have to suspect. If you can't wash out your carbon dioxide, so either one thing is there has to be pneumonia, which is kind of obliterating your diffusion, or there can be air or fluid, right? So then you have to suspect whether there's any complication, right? Okay, so any questions on this? Are you all clear, or do you have any questions? Right, okay, then let's move on to the next. Right, so can you see my screen? Right, so this is your next case. So who's going to discuss this? I hope you can all see this screen.
Excuse me, madam. In the previous one,
Yes.
why do we get lactic acidosis in salbutamol, madam?
Puta, salbutamol, it's a side effect. So it can cause lactic acidosis. So it will accumulate lactate levels inside your body. So when you are toxic with salbutamol, so that is how we usually monitor. So if you see that lactic level is going up, so that means salbutamol toxicity. So it's a known feature. So you can be questioned in your common MCQ. So that's a side effect of IV salbutamol. Did I answer your question? Is it clear?
Yes, madam. Yes, madam. Thank you, madam.
Yes. So who's going to discuss this case? Okay. So we have finished our respiratory cases. So we are moving on to the serious. So who wants to discuss this one?
Madam, madam, in this case, she was treated for a viral illness, but this can be a rheumatic fever. So this time presenting with vomiting and associated with sweating and faintishness, probably due to a cardiac cause. So she was started an asthma prophylaxis, which did not respond to that exercise-induced shortness of breath, suggestive of cardiac disease. So probably a rheumatic fever, complicated with a valvular heart disease later on.
Very good. Why did you think about rheumatic? What is given in this history?
Bilateral knee joint swelling and fever.
Yes. Can you see? There's a past history which happened 3 years back, but it has treated as viral illness, but where she had some arthritis. So most of the time, so we are the common thing is rheumatic. So most of the time when you go back to the history, sometimes you might find something. Yes. So very good. So this is rheumatic carditis leading to heart failure. I don't agree because it's not only carditis. So you can see exercise-induced symptoms and some faintishness. And as for the etiology, you can think about rheumatic. All right. Okay.
Madam, one doubt, madam.
So
usually rheumatic excuse me, madam.
Yes.
Madam, rheumatic arthritis causes mitral stenosis, yes, madam. Following that, heart failure takes several years, isn't it, madam? Could it occur within 3 years?
That is usually in adults, but most of the time, children, they present with mitral valve regurgitation rather than mitral valve stenosis. And they sometimes can present with cord rupture of the cord. So, so that's the presentation in pediatric population. So when you have mitral regurgitation and ruptured, the cord, so they can develop heart failure. So it's not the mitral stenosis we see in children. So most of the time we see mitral regurgitation.
Thank you.
Yes, yeah. All right. So what else in the history you would ask? Anything? So yes, this could be rheumatic carditis leading to heart failure. What else you would ask in the history?
Is she in any prophylactic, madam?
Okay. But this was, of course, as you can see, it was not diagnosed before. Last time it was treated as for viral illness. The question is, list two important pieces of information for you to arrive at the diagnosis. So we are asking about how to diagnose rheumatic carditis here. So what else you need to ask in the history? Basically, we are asking about the diagnostic criteria.
Madam, preceding sore throat.
Sorry? So what are the diagnostic criteria?
Jones criteria.
Jones criteria, okay. What would you ask?
Joint pain, carditis, nodules, subcutaneous nodules, erythema nodosum, and Sydenham chorea. And Sydenham chorea.
Okay. Okay, Sydenham chorea usually it's a late finding. You can see. Okay, what else? So you can ask history, sore throat, whether it's recurrent arthritis, and subcutaneous nodules, murmurs, changing murmurs. So all the criteria, signs and symptoms you need to ask. Right. So how would you manage now? So this child, 12-year-old, presenting with vomiting. So on examination, there's a cardiomegaly. Apex is in the 6th intercostal space in the anterior axillary line. And so she has a hepatomegaly of 2 centimeters. So how would you manage this child?
Madam, excuse me.
Mm-hmm.
Madam, in this case scenario, madam, you have mentioned that this is bilateral knee joint swelling, madam. Usually in rheumatic fever, madam, isn't it migratory polyarthritis that occurs where one joint at a time is involved, and once the inflammation resolves, the other joint get involved, madam?
Yes, that's very good question, Puda. But mind you, this is 3 years back, right? So this is what they will tell you. Ammala danine hai fleeting arthritis. So what happened was this rheumatic fever was missed during that admission, and now she's coming as a complication because whoever has managed this child has missed that, right? So this is a clue. I know this is not a presentation. So they will tell you, okay, had joint swelling. So this is actually giving you a clue to think of rheumatic. But unless you ask, and this happened in 3 years back, so this is what. But your argument is true. But sometimes, unless you ask specifically, you won't elicit this. But this is basically to give you an idea. This Baba had rheumatic arthritis prior, causing this carditis, because most of the time the rheumatic carditis, when you go back the history, you can find some clue in the history. Just to give you that idea, I have included this Puta. But you can be given case scenarios like this. So this is sort of a hint. So by kind of reading this, you should be able to identify the things I'm trying to, we are trying to tell.
Okay, madam, I got it. Thank you, madam. Yes.
Okay. So how would you manage? So this is the management of rheumatic carditis leading to heart failure. So what are the management strategies? So heart failure management is universal. So what you need to do? So I told you there's the cardiomegaly and hepatomegaly. So what does that suggestive of? This child is having congestive heart failure. It's not only the left side, it's the right side as well. So it's a congestive heart failure. So how would you manage? So what are the strategies? So to reduce the volume, what you need to do?
Restrict the fluids and start measurement.
Okay, very good. So you have learned this physiology, right? Cardiac physiology. So use the terminology. So you have to reduce the preload as well as the afterload. So you are using loop diuretics, spanlactone to reduce your preload and afterload by using AC inhibitors and receptor blockers. Right. What else? So I have given it here, basically the management. So bed rest is important and you have to reduce the cardiac overload by restricting fluids. And the most important thing here is steroids. So in rheumatic carditis with cardiomegaly, you have to treat with steroids first before starting aspirin. So you start steroids few weeks and then only you have to go and start on aspirin. Why? Sometimes aspirin has so it usually causes water retention. So if you straight away go and start aspirin first, so always you give steroids and after a few weeks, you need to start on aspirin. And what else you need to do? So you have to do the primary prevention as well. So you have to start on oral penicillin. So that is basically your acute management. So how would you arrange the long-term management here? So this child is having a rheumatic valvular disease causing heart failure. So what you have to do in the future? You have to prevent further damage. Sorry, Buddha?
Parental counseling regarding this disease and starting on prophylaxis continuously.
Okay. What would you start? How would you start?
I would like to advise them regarding. Sorry, madam.
Yes.
Madam, I would like to advise regarding the disease and the consequences of the disease and the necessity to get the prophylaxis regularly, lifelong prophylaxis. And this is a lifelong disease. So I would like to tell you the information.
How would you give prophylaxis? How frequently you would give? How much?
It's IM benzathine penicillin. IM benzathine penicillin given every 3 weeks, madam.
I can't hear you.
IM benzathine penicillin, madam, given every 3 weeks, madam.
Tell me again, Puta. There was a problem with the connection, so I didn't hear you properly. 3 weekly, what would you give?
IM benzathine penicillin, madam.
Okay, all right, good. So every 3 weekly, do you know the dose? It's okay. How long will you give?
Lifelong, madam.
Sorry? Now he's 12 years neither. So how long would you give this?
Up to 21 years, madam.
Okay. So there you need to learn about your rheumatic this thing. So this child is having rheumatic carditis and cardiomegaly. So where your prophylaxis can go up to 40 years or sometimes lifelong. Because idea of giving this prophylaxis is to prevent further damage to the valve. So the 21 days or 5 years is only for uncomplicated rheumatic heart disease. But if there are complications, the duration can prolong. Can you understand? So here it has led to cardiomegaly and heart failure. So in that case, you have to give a longer course of prophylaxis. So usually we are giving benzathine, penicillin as intramuscular injections. But sometimes in adolescent age groups, they are not very compliant with the injections because it's very painful. So we might need to change over to oral penicillin. But other than the other things you have to think of, you have to advise on the oral hygiene. You have to give them the infective endocarditis prophylaxis. You have to prevent sore throat. You have to manage sore throat. And as you mentioned, the counseling. And later, they might need valve replacement. So they need regular monitoring. So Lamai, it's mandatory for you to learn about rheumatic heart disease management. So just refer the American Heart Association rheumatic carditis guidelines. So you have to know about this management. Right. So any question? Any question on rheumatic? Then shall we quickly move on to this case? This is a very long,
Madam, a small clarification, madam. In this case, this patient presented with an acute heart failure, isn't it, madam? So do we need to write the management of the acute heart failure, such as GT and infusion of CPAP, those things, madam?
Puta, the heart failure management in medicine, in adults and pediatrics is completely different. So basically, we don't use TTN in the first place. So as I mentioned you before, so we basically address the preload, afterload, and the contractility. So so the medications we use in adults and pediatric, it's a little bit different. So usually we go for diuretics and AC inhibitors, very rarely digoxin, but we don't use TTN. Right.
Thank you.
So children, they are not mini adults. That's what you need to understand. So we can't apply everything we use, we practice in adult medicine in pediatrics. So it could be completely different.
Excuse me, madam.
Yes.
Yeah, in this case, the heart failure is it due to the acute onset of rheumatic fever or a past history of a cardiac disease leading to cardiac failure?
Yes, 3 years back, that child has there's a history of rheumatic, infection, possibly with a rheumatic carditis, which was not addressed, and repeated exposure to infections has led to cardiac valve defect causing heart failure. So that's what you need to think. So because we have missed it at that point, so it had led to this, heart failure. So the heart failure could be acute.
We have to give the steroids and other drugs as like managing an acute carditis.
Yes. So acute management, you have to give steroids, but you have to tail off within 2 to 3 weeks. So it's not for a longer period till you get this cardiomegaly resolved. So you give for a certain period of time, and then you stop. Actually, you tail off and stop, and then you start on aspirin. Did I answer your question, Puta? So usually we don't give longer courses of steroids. It's during the acute illness we give a course of steroid. Is it clear? Or did I? Okay. So who's going to discuss this? This is a very short, very easy one. Just read and tell me what's the most likely diagnosis. Anyone? What is the likely diagnosis here?
Madam, VSD, ventricular.
Okay. Why do you think it's a ventricular septal defect?
It's a pansystolic murmur heard at the left sternal edge, madam.
All right. And do you think it's a complicated one, uncomplicated one, just a simple VST? What do you think?
An uncomplicated simple VST, madam.
Why?
Not VST because there are no parasternal heave or thrills. And
yeah. What is this parasternal heave suggestive of?
Right ventricular hypertrophy, madam.
Okay. Mm-hmm. And as you can see, child is having very good growth, right? So growth is satisfactory. And yes, basically, as you correctly mentioned, it's a simple ventricular septal defect. So are you all agree with that answer, or do you have different thoughts? So let's see what happened to this child. So what happened here?
Madam, congestive cardiac failure because he has bivasal crepitations and hepatomegaly is there.
Okay, good. So what happened was they had defaulted the clinic, and then after 2.5 years later, their child is presenting with congestive heart failure. Okay, right. So how would you manage? Again, the same principle. So we already discussed about the heart failure management. So what I need to highlight first, so as you can see, it's a shunt lesion. So you have the ventricular septal defect where the shunt is from the left to right. So what happens here? Because blood is going from the left ventricle to the right ventricle, what happened to the pulmonary circulation? It's more. So they are more prone to get pulmonary edema, and then as a result, left heart failure and later on congestive heart failure. So what should be the management strategies? One thing, you have to reduce shunt, and then you have to reduce the pulmonary flow. So that's why you have to reduce preload, afterload, fluid restriction. And the other important thing is oxygen. So what happens if you give oxygen here? Suppose first thing in adult medicine, if you suspect heart failure, what is the first thing you do reflexly? Just to give high flow oxygen, isn't it? You just start oxygen. But what happens? What will happen if you give oxygen to a shunt lesion? What is oxygen?
Madam, in this situation, madam, in
yes.
this situation, if the oxygen was given in the high flow, it is a vasodilator in the lungs. That means the flow to the lung via pulmonary artery will be high. That means the negative pressure built up in the right ventricle. That means the shunt will be increased. That the blood flow to the left side to right side will be increased. That means the lesion will be increased in the size.
Yes, very good. So not the lesion increasing, but you are causing more trouble. So what I wanted to highlight here is oxygen is not the solution for everything. So especially if you have a shunt lesion, as you correctly mentioned, so it's a pulmonary vasodilator. So it will dilate your pulmonary circulation and more blood will go to the pulmonary system by causing more pulmonary edema. So you have to be very cautious when you are giving oxygen to a child who is having heart failure secondary to shunt lesion. So that's the only difference you have to learn on management of heart failure, right? But the rest is always the same. Right. So just tell me what are the indications for VSD closure out of these 5? Just MCQ. When would you decide the VSDs need surgical closure? Do you think first one is an indication, severe failure to thrive? Yes, it is an indication, right? And then heart failure not responding to adequate medical management. Yes, you have to first start medical management, but despite that, if your heart failure is not responding, that is an indication. And if there are episodes of infective endocarditis with vegetations, it's an indication. Muscular defect is not an indication, but the development of pulmonary hypertension is an indication. So, right. So as you can see, so all these are true except for the 4th one. So again, you should know when to refer for the surgery and indications for surgical management. Right. So last case. So what happened here? So child with tetralogy fallow coming with irritability and worsening cyanosis. Saturation on air is 62%. So what is the most likely cause for this presentation? So what has happened here? Child with a cyanotic heart disease. The heart disease is tetralogy fallow and coming with deepening cyanosis with irritability, which was sudden in onset. And the saturation is very low, 62%. So what is the most likely cause for this presentation? Anyone? Have you heard a condition called hypercyanotic spell? I'm just feeling like talking to myself. Can you hear me, Lamai?
Yes,
so here the typical presentation of a hypercyanotic spell. So what happens in hypercyanotic spell? For that, you need to know what happens in a tetralogy fallow. So what are the 4 defects in tetralogy fallow? So you will see overriding of the aorta, right ventricular hypertrophy, there's a ventricular septal defect, and pulmonary tract obstruction. So what happens? Right ventricular pressure is more than the left. So VSD, you know, if it is a normal VSD, shunt would be from left side to the right. But because of this right ventricular hypertrophy and pulmonary stenosis, the pressure is high compared to left on the right side. So the shunt will be from right to left. So that's what happened in tetralogy fallow. That's why you would appreciate cyanosis. But in what do you call hypercyanotic spell? In some instances, usually these episodes happens in early morning when they are upset after a crying episode. What happens is, due to an unknown etiology, this in the infundibulum, in the pulmonary valve, goes into spasms, and it will completely shut down the pulmonary blood supply, increasing the pressures and causing more shunting from right to left, causing more desaturation in your systemic circulation. Can you understand? So that's what we call as hypercyanotic spell. So sudden deterioration of the cyanosis due to the worsening of the shunt. So how would you manage this? So management, what you have to do is you have to reduce shunting from right to left. So what you have to do? You have to increase the pressures from the left side and reduce the pressures on the right side. So what are the actions you can take? First thing, what we explain them to keep the knee chest position. That is, we ask them to flex their hips and broad their knees to the chest. So by doing that, we are increasing the systemic venous resistance. By increasing the systemic venous resistance, we are increasing the left ventricular pressure, which will reduce the shunt. And then other thing, we give 100% oxygen. Oxygen, as we discussed before, it's a pulmonary vasodilator, so it will improve blood circulation into the lungs. And then it will allow blood to flow into the pulmonary trunk rather than going into the left side. And the next thing is you can give some morphine. So morphine, again, it will reduce your tachypnea. And again, it will reduce your pulmonary vascular resistance and then reduce the shunting. And then you can use some bicarb to correct the acidosis. And you can use a vasopressor, kind of a noradrenaline, to constrict the peripheral vasculature. So by constricting the peripheral vasculature, you are increasing the pressures on the left side. So it will reduce the shunt. And the other thing is you can give a beta blocker like propranolol. So it will reduce the infundibular spasms in the pulmonary area. And then you can again give a fluid bolus to improve preload. So these are the basic management steps behind hypercyanotic spells. And I have, bold the kind of theory behind using these steps. Did you understand, Lamay? Or is it like Greek? So just leisurely read. So you should know about this hypercyanotic spell and little bit about cyanotic conditions. And you can be questioned about the management. So this is an area you should know. Is it clear, or you want me to tell this again, or any area you want to clarify?
Clear, madam.
All right. So as you can see, so it's an episode of hypercyanotic spell, and then you know the immediate management. So the next question. So what are the complications of cyanotic heart disease? So what are the complications they can develop?
They can have a failure to thrive, madam.
Okay,
and
good.
Recurrent chest infections they can get.
Tetralogy fellow, will they develop? Why do they get recurrent chest infections? Due to pulmonary edema. Usually. It's a complication of a shunt lesion, Putta. If there is high pulmonary blood flow like VSD, PDA, you will expect recurrent chest infections. But tetralogy fellow, you will not see increased pulmonary blood flow. So it's not a common complication of TAF. Are you clear?
Yes, madam.
So you can't name recurrent chest infection as a complication of TAF. Yes, failure to thrive, they can have failure to thrive. What are the common complications? Complication, reduced cerebral abscess. Very good. Cerebral abscess. Why? What's the reason behind that? Why we need to, what's the action of what does the lung do? Why we need to send this deoxygenated blood? Yes. Yes. So what are the cells? So you have Cooper cells in your lungs. So main action of Cooper cells is to remove all these pathogens, microorganisms. But here, Tetralogy fellow, what happens is they bypass the lung and they directly goes to the systemic circulation, causing abscess, right? Cerebral abscess. Okay, what else they can get? What else? So what happens when they are having cyanosis and mixing of oxygenated and deoxygenated blood? What happens? So they are having a relative hypoxemic condition in the blood. So as a result, it's a stimulation for your erythropoietin. So as a result, what happened? They will produce more and more hemoglobin, and they are polycythemic. So as a result, what can happen?
Hypercoagulable state.
Yes. So they are more prone to get thrombosis because they are polycythemic, and they can get thrombosis everywhere, especially in the cerebral circulation, cerebral arteries and veins, because of this reason. And then we talked about brain abscess, failure to thrive, but apart from that, they can get bacterial endocarditis, arrhythmia. But you should know a little bit about pathophysiology about cyanotic heart disease and its complications as well. Right, so what do you do for tetralogy fellow? So now this child comes with a hypercyanotic spell. So apart from the acute management, what else you should be doing on the long-term management? What else you have to do? So what is the definitive treatment for tetralogy fellow? So as you can see, so there's no enough pulmonary blood flow. So definitive treatment would be the correction of this defect. So we are going to close the VSD and we are going to open up the pulmonary artery. But in a small heart, it's not feasible because of the anatomical deficiencies. So what we do is we take a temporary measure. So what do you call that surgery? We put a BT shunt. Yes, so we put a temporary shunt. Yes, very good. So we put a temporary shunt from the subclavian artery to the pulmonary artery and then improve the blood to the lung. But this is a palliative sort of a procedure. When they grow old, we can go for a corrective surgery. But till that time, because nothing is going on from this pulmonary trunk because there's pulmonary atresia. So what we do, we take the subclavian artery or branch of a subclavian artery and we connect either to the left or the right pulmonary artery and increase the pulmonary blood flow. Understood? So that's what we do by doing a BT shunt. So if a child comes with a cyanotic, hypercyanotic spell, that is the next definitive treatment. So you have to refer this child for a cardiologist to arrange a BT shunt insertion. That means that child needs a BT shunt to maintain saturation. And apart from that, they can have the other problems like polycythemia. Sometimes you might need to do venesections. And because if they get iron deficiency, so because iron deficiency can cause abnormal size and shapes in the red cells, so they can cause anisopoikilocytosis. So they are more prone to get thrombosis. So it's mandatory for you to treat iron deficiency and mandatory to monitor MCV. and then you need to arrange a BD shunt and then plan for the corrective surgery. So that's how you should be doing when you are managing a child with a cyanotic heart condition. Is it clear? Do you have any questions on that? So basically, this is what you should know. So in cardiac lesions, there are acquired causes and congenital. So acquired, under acquired, you should know rheumatic, Kawasaki, infective endocarditis. So these conditions you should know. And then congenital, we can again divide into acyanotic and cyanotic. Acyanotic, you have shunt lesions like VSD, PDASD, and you have obstructive lesions like aortic stenosis, pulmonary stenosis. Whereas in cyanotic conditions, you have tetralogy of Fallot, transposition of great arteries, and other admixture physiologies. Are you clear? So you should have some broad idea about the cardiac condition, cyanotic and acyanotic, and the problems. So what is this? This is the X-ray of the same child.
Boot shape heart.
Yeah, so this is boot shape. So in which condition would you see boot shape heart?
In the tetralogy of Fallot.
Yeah, in tetralogy of Fallot. So as you can see, because of the right ventricular hypertrophy, you can see the elevated apex. So it's like exactly like a boot. So this is a boot shape heart where you would see in tetralogy of Fallot. So what is this? ඔයාලට මේක figure of 8 වගේ පේනවද? මේක 8ක් වගේ පේනවද? So there's a condition called TAP-VD. So in that condition, you අපි මේකට කියනවා snowman appearance කියලා කියනවා. So in total anomalous pulmonary venous drainage. So where you the pulmonary veins will not open into your right ventricle. Instead, they will open elsewhere. So you will see a figure of 8 or snowman appearance in that heart condition. And what is this? What is this? This is an egg. So can you see this is egg on a side? Egg එකක් side එකෙන් බැලුවා වගේ. So this is exactly the X-ray finding of a child with transposition of great arteries. So when you have transposition, so you will see the heart as a egg on a side. So I just wanted to show you few X-ray, X-rays of congenital heart diseases where you would expect some characteristic features. Right? Any questions? Okay, so if you don't have any questions, Lamai, so we'll wind up for the day. Have a nice day. Bye.
Thank you, madam. Thank you, madam.
Thank you, madam.
Recording stopped.